Good afternoon, everyone. Thank you for those of you who made it back on time. We appreciate it because we have an amazing speaker for you. We were hoping that Sassy Outwater-Wright would be here with us in this room today. And she tried to the very last minute to make that happen, and unfortunately, we're going to have her audio only coming to us from Berkeley, California. But let me tell you a little bit about Sassy and why she is so special and why we will take any bit of connection with her that we can. So Sassy is an interfaith chaplain, clinical care chaplain, and a certified patient advocate. She's also an internationally known disability justice activist and has spent over 20 years in the web accessibility and digital health equity patient experience field, as well as a user experience subject matter expert. She also was first diagnosed with retinoblastoma when she was 6 months old. She's been totally blind since infancy and has faced cancer 5 additional times. And the reason why she can't be here today is she's currently in a late-stage metastatic leiomyosarcoma patient at UCSF, and her palliative chemo was not kind to her this past week. And her family, she lives in Berkeley, California, and Salem, Massachusetts. So like me, she loves both California and Massachusetts. And most recently, she was executive director of the Massachusetts Association for the Blind and Visually Impaired. She's also a Renaissance woman, a professional musician. She enjoys cooking, gardening, and traveling the world with her guide dog always beside her. And that's Sassy on paper. That's all that, check all the boxes. But I also wanted to say personally, we're so lucky to have her with us today, and she has made Herculean efforts to be with us. And I know she desperately wanted to be here with us and to be in the ocean of Hawaii. And I'm just, but we will take any connection we can with her because she is a gift. She is brilliant, and she chooses to use her brilliant gifts to help others. And she's done that her entire life. And I will be forever grateful to call her my friend. Thank you, Sassy, for being with us today.
Hello. Thank you, Marissa. Wow, that was quite the introduction, and you got me tearing up too. Some of the people in this room I've known since I was an infant, I'm sure, and some I've never met, and I'm still hugging all of you like I've known you my whole life because that's just what I do. And I want to start by kind of tightening up on what she said I do right now. Right now, I'm facing cancer. And that's what I do. In a couple of hours, I'll go off and I'll be the chef who makes dinner, or I'll be the laundry person who makes laundry get all clean and folded and back in the drawers, or I'll be the dog dinner delivery person who scoops the kibble into the dog bowls and feeds the dogs. You are what you are when you're doing it, and you are something else when you're not. Now, what do I mean by that? Because we're collectively all of the things that we are. I mean that once you are something, it never quite leaves your bones, as in how you do it, but you move on to the next thing and the next thing and your next thing. You're not always doing the same thing over and over and over, but neither are you abandoning it. And so a few weeks ago, when we started talking about what I would be talking about for today's discussion, my mother said to me, well, no, you can't talk from the point of a cancer kid. And I said, Mom, once you're a cancer kid, you're always a cancer kid. That does not leave you. And that might be an unpopular opinion, but so be it. But there are a lot of us out there who do have a fine point on this, which is that cancer itself, when you get it as young as you do with retinoblastoma, it builds a certain set of characteristics into you that you get to know really early in yourself. And I don't look for the good things in RB, but I do look for the things that made me who I am today in RB. And one of the best things that I've noticed in myself about being a cancer kid all my life, since I was a cancer kid, is that I have learned to become aware of what tools it takes me personally to be resilient. I have learned what tools it takes me personally to be heard and to be listened to. Because if I wasn't, I would be in a world of pain. I would be not feeling well. And so very early on, I learned either you hear me or I push back until you do, which made me a very stubborn kid growing up. But it also made me into a very good person at what I do in my adult career. That as an advocate, I can push and push and push and not take no for an answer. Because I can't take no for an answer. If I have a patient whose life depends on what I'm saying or what I'm doing in my professional career, I can't take no for an answer. I need to get that patient's needs heard. And that is a big goal that sits on my shoulders. And so, us RB kids who may be small learn at a very early age what makes us our all. And that's kind of a cute little saying that somebody told me once in the RB community. No, it did not come from my brain. Um, but I found it very true. What turned us into ourselves at a very early age was not the cancer, though. It's being in an environment where the doctors need to know from us at every moment how we're doing, how we're feeling, why we're feeling that way. Um, and as I started thinking about my life and looking at it in a little bit of a retrospect, not because I'm on palliative chemo, but because I like reviewing life and what it has taught me. I'm that weird and that boring. Um, I like looking back at what life has taught me and drawing something forward from it to give to the now in my life. And when I started doing that, I started realizing there's some tools that I could put together as a healthcare chaplain, as a patient advocate, a family counselor, that I could put together to help families get through this. And they were just based on simple ideas of emotional awareness, energy awareness, awareness of other human beings in your space. And those were the most important gifts my mom and the social workers and doctors and nurses on our team gave me. And they were things like being aware of what energy other people are bringing into the room. And if you're not, learning how to be aware of that energy, and to ask and confirm that energy or offer something to help them take a pause and shift their energy, or offering yourself something to shift your energy so that you're more aware of each other. And so my way of doing this started with a mud pie. Um, I was that kid that liked to play in the mud and disturb the neighborhood, let alone my mom did not care. She just threw my clothes in the laundry and was proud that her kid played in the mud. She was the one who encouraged it. Don't tell her I told you. But yeah, I loved to play in the mud, and I was in the mud last year planting my garden and secretly making a mud pie. And I thought to myself, well, there's all kinds of pies in the world. And pies help us know what kind of energy we have or don't have available to us at any given time. Such as, you know, we always say, that's a whole piece, I want a whole pie, not a piece of the pie. And I'm emitting some strong words we might use. for the sake of smaller ears that might be present. But we might have a piece of the pie, we might have the whole pie. And my pie, my guide dog named Trident or Tri Pie, is sitting here talking and contributing to this conversation. Not time for doggies to talk. Um, and so when we think of, is somebody giving us a slice of pie or are they giving us the whole pie? It's usually in a context of, am I getting the whole experience or am I getting part of the experience? And what I wanted to highlight to people was that they may not have the whole experience to give. They may have only a little bit of themselves available to give that day. And right now, the experience that I would have to give anything but this is, oh, there's a squirrel in my window and he's yelling at me, and my dog is staring at him. I am tired and I am watching things like that to calm me down and to center me. And so I'm giving a squirrel and a dog my full attention, other than this conversation. That's getting my full attention. Behind that, the squirrel and the pie are getting a smaller slice of pie because that's what I have left. There's not much left for anything or anyone else at this time. Mostly, we usually have two or three things that are going through our minds at any given moment that could distract us, that could change our emotional outlook on things. But when you're facing cancer and you're doing it with your family, when you're aware of everybody in the room and when you're aware of what they're bringing that day, and you are okay, and you let them know that you are okay with whatever they're bringing to the room that day, and you give a reason to help each other, whether somebody is lower energy and so they have less pie that they're bringing today, or they have a whole pie to bring to help somebody that day. And it's not something you can, gloss your way through or pretend. This is a true as true gets kind of statement. So if you're going to say you have a whole pie, you better, make that whole pie real. And so to do that, we drew pictures of it, or in my case, made a mud pie of it. And that's how I discovered this. But drawing pictures of it or doing tactile artwork of it, and creating more and more opportunities for you and your family to exchange awareness of where the other is in that moment helps each other come center, helps each other come to an understanding of where each of you is in that moment. And when you go in together, aware, understanding, not just empathizing, but compassionately participating with each other to the point where you're willing to check in honestly about yourself to someone else. Yes, that is compassionately participating. Checking in with yourself about where you are to someone else is compassionate participation. That is honesty, and that's what kids who are facing RB come to know, come to love, is that adults feel comfortable hearing from us, but we also need to hear from them. And we need to have that exchange because we want to feel able to be included in the places where we feel most comfortable. And that's with our family, with adult, with anybody who can hack being with a cancer kid. And that's not many people, trust me. But when you can, being able to share your energy, share where you're at in that moment, and share that you're looking for someone to help you. Giving a kid a chance to help, a chance to turn things around and be the helper instead of the helped. This goes a long way. And what I want to carry forward now for all us RB kids who lived that way as RB kids and now are facing it again facing cancer again as RB adults who have the RB1 mutation, who are at high risk of second cancers, second primary cancers. Think back to when you were a child. No matter when you faced RB, one thing I think universally we each picked up is the ability to be aware of the energy going on around us, the emotional energy, the mental and physical energy, because it was what told us how our hospital day was going to go. So, as you're facing forward into if cancer comes next for you, or if ongoing survivorship care is next for you, as an adult facing RB and the ongoing effects of RB, stop and think back to when you were a kid and carry those skills that you developed as a child, because they are skills. They are things that gave us skills in this life, and we need to treat what RB left in its first round, and we need to treat that with a level of recognition and respect for what we became as we came out of RB. We beat it once. Yeah, we can look at doing it again because we became good advocates. We became very aware of what was happening to us. We became very aware of reading the energy in the room. And I want each of you to be thinking deeply about how to shift the energy in the room when you are in a spot to be the helper or the helped. Look at shifting the energy. Look at providing for others as they provide for you. This is how we create a collaborative community and how we instill in our entire community that we are all surviving of and for each other and caring of and for each other. We are here for each other. And that's true whether you're sitting in a hospital bed dealing with another round of cancer or you're up supporting an RB friend who is. Whether you're getting your survivorship care done or you're advocating for it to be done and offered where you're living. We're all of and for each other in this community. And I hope that each of us carries us forward in that mentality and that we listen to those who have gone before us, who know what we don't. And we get good with asking. We get good with another childlike trait, which is curiosity. So far, we have playing in the mud, asking questions, making artwork, curiosity. Yeah, we're doing great at keeping the child alive here. So be aware of the joy that childhood brings, and that never growing up and maintaining your childhood, your child, your cancer kid status through your whole life. Yeah, we're good at that. So look at all those traits that you developed as a cancer kid and take them forward with you, because they are some of the most adult things you will ever learn. And I hope that you take them forward with you in advocacy, in friendship, in art, like mud pies, and in food. Because now I want some pie. That sounds really good, but not mud pie. I promised my mom I wouldn't eat worms. And if I didn't eat worms, she'd let me play in the mud. And with that, I'm going to hand it back to Melissa. And Melissa, if it's okay, I'll offer any available space for questions um, with just a couple minutes left. But if there's any pressing questions around follow-up survivorship care, around secondary primary cancers, around blindness, if you don't reach me today, you can always reach me at chaplainsassy@gmail.com. Again, that's chaplainsassy@gmail.com. And just drop me a question. I'm happy to answer what I can or get on a phone call with you if I can't answer by email, and to help you out if you have a particular question regarding RB. And thank you so much, Marissa and Melissa and all the others, for making it possible for me to be here, even if I couldn't be there. Oh, I wish I could, but we're loving you from California, and We are hoping all of you have a wonderful week and enjoy each other's company and learn so much together.
Thank you so much, Sassy. We have time for one question in the room, if anyone would like to ask. Okay, thank you so much, Sassy. Okay, next we'd like to ask the adult survivorship panel. Survivorship panel, come to the stage, please.
All right, everybody. Let's give up one more round of applause for Sassy. Sassy, if you're still on the Zoom, thank you so much. We wish you could be here in person, but we are so thrilled you were able to join us virtually, and we're sending lots of love. Once again, my name is Marissa Gonzalez, and I'll be moderating the Survivorship panel. Survivorship is definitely a passion point for me within the retinoblastoma community. I'm going to just share real quick before I introduce our first panelist. On St. Patrick's Day of last year, as I was leaving my godson Simon's 7th birthday party at Chuck E. Cheese, promise this is going somewhere, I got a call from my dermatologist with 3 little words that, even though I knew were very possible I would hear, still shocked me. Marissa, you have cancer. Obviously, I was a baby when my mom heard those words, and I was an adult when I heard those words. But there are 3 things that I had done in my survivorship journey that helped make not only this diagnosis, but the subsequent surgery, the subsequent removal of 1/3 of my nose and skin graft from behind my ear to reconstruct it, easier. Number 1, genetic testing. Number 2, genetic counseling. And number 3, being in a survivorship program. Learning about the second primary risks of the RB1 mutation, what those meant for the rest of my journey, for my potential reproductive future, for my potential second primary cancer future, and all of the fun things that come with being a survivor have helped me take the reins as an adult in my own healthcare journey. So I'm very excited to be moderating this session because I really want survivors in the room and parents in the room to know it is so important for you to advocate for yourself, and when your children are age appropriate, which is different for every child, involve them where you can in the decision making, in their treatment, in even if it's just picking out what color Band-Aid you want because it makes them feel like they have a little bit of control. Being your own advocate is so important. And so with that, I would like to introduce my personal cancer survivorship doctor, coming from the Keck School of Medicine of the University of Southern California, David Freyer. Woo!
Thank you, Marissa, and thank you and the organizing committee for the opportunity to be here. Again, this is actually my third conference, I'm happy to say. The first one was in 2017 in Washington. Then I think there was one that was virtual in there somewhere, and now this one. And really, every time I've been so grateful to be here because I learned so much from my medical colleagues, but also from all of you. You know, you impart your wisdom that makes, that humbles us and humbles me in particular, and helps me remember what I hope to accomplish as a physician. You know, your courage, honesty, authenticity, all of those things really have helped shape me in a good way as both a person and a physician. So I just want to thank you for that. I do have a few slides here just to kind of help keep me on track, and Marissa's a tough taskmaster, and I think told me 10 minutes, no more. So I took 2 slides out, I just want you to know. And we'll just jump right in. So first of all, just to kind of get us all on the same page, who is a cancer survivor? It's really anybody from the point of diagnosis onward. Now, you know, pragmatically, we often think about, and in my field of survivorship, as patients who are off treatment and many years down the road. But technically speaking, it begins with the time of diagnosis, and it actually encompasses more people than just the patient. All the family members who are impacted. All of you, all of us are survivors in that sense too. And cancer survivorship is really anything aimed at improving physical and emotional health and quality of life after that diagnosis of cancer has been made. Cancer survivorship clinics is where we deliver some aspects of survivorship care. And care that we give in survivorship clinics are focused on the needs of survivors. And I'll talk about each of these with one slide each in a few minutes. The first is to monitor and help manage what we call late effects, or those are long-term side effects after treatment. The second is to educate about health risks and prevention. I think you can appreciate how important that is in the world of retinoblastoma. And then equally important is addressing the emotional development, informational, and financial challenges that cancer survivors routinely face. The care is delivered by a multidisciplinary team. Physicians play one role, but also advanced practice providers. That's alternative language for nurse practitioners or physician assistants, social workers, and then many others. And again, I think that we all know how important the multidisciplinary team is in the care or in the acute care for patients newly diagnosed with retinoblastoma, ranging from the surgeons to the prosthetists to social workers at the front end. But that reliance on an interdisciplinary team continues into survivorship. But the one thing we all have in common is sort of a shared commitment to cancer survivorship and the issues that are important to our patients, and a real commitment to doing the best that we can. So the bottom line for retinoblastoma and cancer survivorship clinics is listed here. First of all, who should be referred? I believe that any adult or child who's been treated for retinoblastoma deserves to be seen in a survivorship clinic. Why refer? It's to address the issues that I mentioned before: health related to the retinoblastoma, genetic status and prior cancer treatment, screening for and managing late effects that could occur, health risks and wellness, trying to counsel to promote the best quality of life and health that we can help that person attain, and then to receive the psychosocial support and resources that we've heard about already today. First of all, medical monitoring and management. So I've listed a few things here that fall sort of under this rubric. One is ensuring, and clearly we don't do all of these things in the survivorship clinic, but as the clinic team, we want to be the medical home for the person so that they've got a place to turn to in order to get all of these things that need to be delivered actually by specialists. So I'll just mention them as ensuring that vision is as optimal as it can be. That requires, of course, an ocular oncologist or ophthalmologist. Ensuring appropriate prosthesis fit and function. Screening for hearing loss that can happen after chemotherapy, some types of chemotherapy at a very young age. Screening for neuropathy, which can also occur from certain types of chemotherapy that are used. Screening for other types of late effects that we may need to think about depending on the type of treatment that the patient received. Ensuring that retinoblastoma gene testing is complete, interpretable, and I would add up to date. One of the things that I've really learned, it's been imprinted on me over the past recent years, is just how much this area has changed and evolved and improved in recent years. The testing that was done 15 years ago is not the testing that's done nowadays. And I think for patients who have had older testing, getting that updated is a good idea. Monitoring for second malignancies if the person is germline positive. Providing and reinforcing genetic counseling goes along with the up-to-date gene testing, and then making sure that other family members who might be at risk are tested and assessed. Psychosocial support, you don't need to hear that from me. We've heard eloquent testimony to that, I think, from our friends and colleagues here that have lived this experience. This is such an important area, and it's something that continues well beyond diagnosis. And in fact, it's something that we see our patients grow into. So assessing the emotional adaptation that's related to vision, functional differences, self-acceptance and confidence, and fitting into peer groups. Supporting the family and the patient with child and parent-directed guidance, anticipatory. Arranging for psychology evaluation and management when it looks like that would be a good idea. And ensuring that school accommodations are both appropriate and adequate. And then finally, connecting patients and families with good organizations like this one so that they can receive the benefits of advocacy and support groups. And I can't tell you how many times I've written out the URL for this organization and given it to them on my stationery, which is a paper towel, out of my clinic room, but I'll jot it down because they need to know about this organization. And I think anything that can be done to increase the visibility and outreach of this good group is going to help many, many patients. Health information and promotion refers to keeping people well as much as possible and helping them manage their own health. It's part of empowerment. So this entails having a realistic understanding of the risk for certain late effects and opportunities for reducing those risks. I don't particularly like in the survivorship clinic talking about the risks that people have, and not just retinoblastoma patients that are a result of the treatment that they had, because cancer in many ways kind of becomes the story that never ends. The treatment finished for the original cancer, but the risks are sometimes lifelong. I don't particularly enjoy, discussing those things, but they're an important part of self-management, and I think it's our obligation to be as thorough and as honest and straightforward, kind, hopefully, but also straightforward and forthcoming about the things that our patients need to be aware of. So some of those may include hearing loss and avoiding additional trauma to the ear through loud noises. Sorry, those kids here who have ear pods in and have them turned up. We do sort of caution you about that. Neuropathy and addressing that with physical therapy. cardiomyopathy, which can develop from some types of chemotherapy, not so much for the kinds used for retinoblastoma, but just as examples for what we do. And then maintaining weight and healthy diet. And then for second malignancies, obviously a very important topic here is using sunscreen. Although we just learned a lot, didn't we? I did, from that presentation during lunch about sunscreens and the right types to use, avoiding cigarette smoking and avoiding unnecessary ionizing radiation. And then many general health considerations like staying physically active, eating a healthy diet, managing stress, and maintaining weight. Financial challenges are a really important and increasingly important part of cancer survivorship, and we do quite a bit of discussion about this with our patients, especially here in the United States, where the challenges of financing healthcare are so acute and complicated. So the point for a cancer survivor, the point of having financial challenges addressed is to be able to maintain lifelong survivorship care. And health insurance in the United States is usually privately obtained through an employer, sometimes publicly, but it's not universally available as it is in some other countries. So to address that, we like to speak in our clinic about the golden triangle, which is the triangle with one point being education and vocational training, the other with employment, which leads to being able to have employment with benefits meaning health insurance, among other things, and then the third thing, having health insurance. So it's education and vocational training that leads to employment with benefits, which leads to health insurance. And once you can have those three points of the triangle in place, it becomes possible from a financial perspective to deliver the care that our patients need. Healthcare transition is the last point that I want to hit, which is the transition of care from the pediatric setting to the adult-focused setting. And this is something that every child grows into and through, which is a good thing, but there are some challenges along the way. And what the purpose of healthcare transition is to ensure that patients receive lifelong and appropriate care, both for, that our adults are getting their adult needs met, and while children are still children, that they're getting those met appropriately. So ideally, this is intentional, planned, and coordinated, not willy-nilly. It starts early. We identify who the adult care partners are. We work with the treatment team, have a survivorship care plan in place. Every patient should have this. This is a simple summary of the therapy that they've had and what they need to watch out for. Consider the insurance that I mentioned before, and then making sure that the patient and family knows what they need. So just briefly, at our institution, at Children's Hospital Los Angeles and the affiliated USC institutions, the USC Cancer Center, the approach that we use, basically, it's all written out here, but our patients are referred into our survivorship clinic within about 2 years of ending treatment in general. So they're still children at that point. They're followed in our survivorship clinic at Children's Hospital Los Angeles on an annual basis until they turn approximately 20. And then at that point, their care is transitioned to adult providers. Now, if they're higher risk, they continue in a structured, resource-intensive sort of setting at the USC Cancer Center, where I also work. But if they're lower risk, we cut them loose very deliberately from the high-intensity follow-up of a quaternary care center and try to normalize it and get them into more of a primary care setting. So for the lower risk patients, they follow there. So retinoblastoma actually represents both. For the higher risk patients, those are those who have had radiation therapy, in some cases certain kinds of chemotherapy, but importantly a germline mutation which predisposes to more cancers in the future. Those patients are considered to be higher risk and are followed in the structured setting of our survivorship clinic. And then, as I said before, lower risk patients, we actually try to cut them loose and move them out of all of this stuff so that we're not over-medicalizing them and they can, have a life that feels a little bit more normal. So the question that might be important for attendees at this conference is, I'm an adult, but I'm not in survivorship care, what should I do? would make these suggestions. For individuals who are lower risk, meaning that they are not known to have an RB mutation and haven't received radiation therapy or very intensive chemotherapy, they should connect with their primary care provider if they have one, or find one so that they can begin to have annual checkups. Find an ophthalmologist who's comfortable with this, and if more work is needed with your prosthesis, identify an ocular prosthetist. For higher risk patients, I would really recommend contacting a more specialized survivorship program and get in there to be evaluated. Bring your gene testing results if you have them, and if you don't, they can probably assist with making sure that those are done and up to date, and then begin the annual checkups that I kind of mentioned before. Finding a cancer survivorship clinic is easier in the day of the internet, and I've just shown a few examples here. I haven't covered every possible place in the world where we might have attendees from, but from every major country that I've listed here, there are survivorship clearinghouses, if you will, places that you can contact by the internet in order to find out where maybe the closest survivorship program is for you. And are you posting these slides on the website? So if you can't read this from a distance, you'd be able to find it there. So just to recap, for retinoblastoma and survivorship care, any patient, any child or adult has been treated for retinoblastoma. Why? To maximize health and quality of life over the long haul. When? Starting as soon as possible after completion of treatment. Where? In a survivorship clinic if it's available, and for the duration, lifelong, at least for those individuals who are at higher risk. And with that, thank you for your attention, and I'll take my spot back at the table.
I'm just going to stay here. Sorry, I'm keeping the AV team on your feet. It's now my pleasure to introduce our next speaker. Very excited to have Susan Poltman from Children's Hospital of Philadelphia with us. We have a lot of folks here from the East Coast, and Susan will be talking about that double-edged sword of social media and cancer survivorship. Welcome, Susan.
Thank you so much. Before I start, I have to thank everybody who's spoken before me. Quick story, during lunch I called my wife and my son to tell them about the conference so far, and I was going on and on and on about how wonderful it was and how impactful and how these things I'm going to bring back to Philadelphia. And I just got a text message from her before this session saying, Suze, I think you're the only person in Hawaii who's more excited about a conference than the state. So thank you for doing this. So I'm an oncology social worker at the Children's Hospital of Philadelphia, also known as CHOP. We co-treat our patients with the Wills Eye Hospital. My team at CHOP is led by Dr. Amish Shah, and the team at Wills Eye Hospital is led by Dr. Carol Shields. Of the approximately 250 to 300 children in the USA affected with retinoblastoma each year, our team in Philadelphia cares for between 1/3 and 1/2. The majority of my work is with retinoblastoma patients who are on treatment or in follow-up, and I also support the Cancer Predisposition Clinic and the Survivorship Program. My goal in this presentation is to foster open thought regarding the role of social media for retinoblastoma families and survivors, and in thinking about what other forms of connection may be useful in creating a supportive community once retinoblastoma treatment is over. I chose this topic in hopes it would be broadly applicable to the audience here, and because it is a conversation that I have regularly with the families that I serve. I'm going to try my best to get all the information out. I might need some help moving my slides. What am I doing wrong here? Yep. There we go. Quick disclosures as I begin. I want to acknowledge I come to this work as a white, able-bodied, financially stable American mental health professional. That shapes my experiences and my perspective in ways that may differ from those that I serve, including many in this room. I want to acknowledge the difference and the disparity in health systems and resources and in technology that exists worldwide. And I'm a social worker. I don't have any financial interests. For purposes of this conversation, I'm using social media as an umbrella term to encompass services like Facebook, Twitter, Instagram, TikTok, as well as cancer-specific media like the tools provided by organizations such as American Cancer Society and Stupid Cancer. I'm also somewhat considering information sharing sites like Caring Bridge in so much as they facilitate information sharing among families and survivors. Two of my patients' mothers shared some of their experiences with me, which I am extremely grateful for, and I'll be weaving in some of their thoughts throughout this presentation. While they are talking about their experiences as parents, what they have to say is also relevant for survivors and their own social media use. I'm going to call them Mom A and Mom B. Mom A says, "The challenge with finding support of other families fighting RB is that we are spread apart so much geographically. In many ways, social media is helpful in that it has the ability to connect people who would otherwise not be able to connect, and that has been really helpful to us." Retinoblastoma is a rare disease with survivors and families scattered throughout the world. The internet is a wonderful way for people to bridge this divide. As I tell families when I first meet them, there is nobody who knows what it's like to be a parent of a child with retinoblastoma except another parent of a child with retinoblastoma. Social media facilitates a bidirectional flow of information. That is, survivors and families are receiving and giving information, which creates a supportive ecosystem. These are all really powerful and positive things. Patient activation is defined as the knowledge, skills, and confidence to be actively engaged in one's healthcare. The research that I'm going to talk about discusses patients themselves, but I would argue that this is the case for both patients and the adults medically responsible for them, and I'm going to make this assumption for the rest of the talk. This diagram was created by Xiaohei Jiang from Texas A&M University, and it shows that being engaged in diagnosis-specific social media groups can increase patient activation, which directly impacts and affects emotional well-being. You may have experienced this yourselves. You, your loved one, was diagnosed with a scary disease that you know almost nothing about. You go into a chat room or a Facebook group, you hear from other people who have walked this walk, you're armed with information and the right questions and a sense of community standing behind you. And you feel like you have just a little bit more control over the situation. Mom B described it like this: "It exposes me to worse or worst case scenarios on the regular, like a type of training. I feel like RB is a war, and if battles are being fought by other families, I want details of those battles. I want info on my enemy, RB. I don't want to be shocked with anything. I want to prepare." Mom A says, "The bottom line, though, is that we as parents want the success stories to some degree, but we also want to know about the kids who passed away, or the late recurrences, the worst case scenarios, because none of our medical teams ever talk about that as a real possibility. Seeing it all the time on social media makes it seem like it's more common than it actually is. However, when our doctors tell us that something is really rare, it doesn't give us any comfort because bilateral RB itself is very rare and unlikely. Knowing what could happen gives us a chance to prepare our hearts for the worst possible outcome, because no one wants to be caught off guard again the way we were when we first got the diagnosis." So here's the most important piece of this diagram. Emotional management skills matter. In other words, you need to know yourself and how you handle things, or even how you're handling things on that day before you decide to open up that group or click on that link. You get to be in charge of how much information you let in or how much you give out. Or how much, and today is a day when you're feeling on edge and that your mental health is poor. Listen to that. Take a breath, have a glass of cold water, do what you need to ground yourself. Maybe today is the day you want to share your story. Maybe it's not. Maybe it's the day you want feedback on the choices you're making for you or for your child. Maybe it's not. Consider setting a timer for yourself or installing screen time limits on your phone to protect yourself from boundless scrolling. So I'm not going to harp so much on these risks, as I think they're fairly self-evident, but briefly, misinformation is extremely prevalent online. It's not always malicious. The people posting it don't even always know that it's incorrect. but it's there. If you see something concerning, I guarantee that every single physician, social worker, or other medical provider would prefer that you bring it to them for discussion and clarity rather than stewing at home about it. One of my patients' moms shared that families like ours jump on social media to look for anecdotal evidence. The problem with this, however, is that it's highly uncensored, and that makes it very dangerous for the average person. I am still a parent dealing with my own trauma, and sometimes there are conversations that send me right back into the fear of what I did or didn't do, or I grow worried about how other families are taking the information. Secondly, watch out for bullying. Perhaps a kinder way of put it, aggressive advocacy. As one of my patients' moms tells me, the loudest and most passionate voices in the room are not always the most helpful. And if you are one of those loudest and most passionate voices, please take a moment before you post and consider how your words may be received. Please think about the state of mind the people reading your message may be in, where they are in their trauma. I've spoken to multiple parents shortly after reading aggressive social media posts about why one treatment is a horrible choice and why their child might die because of it. They're shaken, disoriented, and destabilized. Please, please, please consider your words and their power carefully. And please remember that just because your own experience went one way doesn't mean that other people's will. And the last risk I want to mention is the emotional risk of re-traumatizing yourself and of bearing repeated witness to suffering, and of seeing stories that hit a little too close to home. Unfortunately, there will always be tragic stories that come out of the pediatric cancer world. Even if those affected have the same grade of RB that you or your child did, even if they were the same age, received identical treatments, you or your child are different. Their fate is not yours. Of course you'll be triggered by seeing these things, everyone is, and it's natural and it's normal. But when you see tragedy unfold on your Facebook feed, again, take a breath, take a walk, take a break. So in this short bit of time, I've mostly focused on social media, but I also want to bring up some other ways to connect with RB families and survivors. And I know I'm probably preaching to the choir here, you're all in this room. But I want to point out a couple organizations specifically, one of which is called Immerman Angels. I think it's one of the very best support organizations out there. Their mission is to provide comfort and understanding for all cancer fighters, survivors, they call them previvors, and caregivers through a personalized one-on-one connection with someone who has been there. They train what they call mentor angels and mindfully match them up for one-on-one relationships with anyone touched by cancer. They work with people all over the world who are touched by cancer in any way. This is a wonderful way to get trained peer support or to give back to the community by becoming a mentor angel. Camps and retreats are another very powerful manner of getting and offering support. There are camps all over the world who exist specifically to support cancer patients, survivors, and sometimes entire families. I started working at an oncology camp when I was 14, changed my entire world, and led me to my career in pediatric oncology. I'd be happy to help anyone find a camp that would work for you. And adult survivors, here's a way that you can especially be a beautiful empowerment source for kids who are going through this. The counselors who are survivors at these camps make a world of difference to the campers. The campers get to see people who have been through it and have survived and thrived. And I can't overstate how powerful that is. And finally, of course, groups and events like the ones we are at today. Whether it's the We See Hope organized events in communities, Stupid Cancer holds wonderful survivorships for young adults, First Descents does retreats, Camp Sunshine has a retinoblastoma family camp. These are just a few of the options, and I'm only referencing US programs. Again, I'd be happy to help you find options in your area. About 2 years ago, I recognized the importance of RB families getting to meet each other for support, and I started to host an online gathering for parents and caregivers treated for retinoblastoma at my hospital. It's an open forum. I hold it every 3 or so months. Parents of children in any stage of treatment or survivorship for retinoblastoma can come and meet each other, share coping strategies and experiences, and create a community of support. As a social worker, I'm prevented by laws and hospital policy from directly introducing families, but this is a workaround. I can create an environment where they can meet in a safe environment. And I can tell you it's produced some really beautiful moments in the group and has led to some really deeply supportive relationships outside. If you're followed at a major RB institution, I would wholeheartedly suggest you talk to your social worker or connect them to me, and I'm happy to discuss how you can start something like this. Thank you so much for this time. I have just kind of grazed the surface of a lot of things, but I hope to speak with many of you after this as well. I also learned that I'm the first social worker to present at the One RB World Conference, so if anybody wants to talk about oncology social work or anything else, please find me. Thank you.
Thank you so much, Susan. That was wonderful. It is now my pleasure to introduce our final presenter on the survivorship panel, Sally O'Day. Sally is here with us from Australia. She has her 10-year-old daughter with her who's enjoying the Child Life program downstairs. And Sally is going to be speaking about something many people in this room have been through, and that is grief after eye loss. So, ladies and gentlemen, please welcome Sally.
Hi, everyone. I just would like to introduce myself. This is who I am. I am not a retinoblastoma survivor, but I am a survivor of a motor vehicle accident at the age of 10 days of age, where I sustained bilateral skull fractures, and they actually had to drain fluid from my fontanelle. This is in the 70s. So that is the only picture up on the top with me with two eyes. The second one down on the bottom of it was me in the 1970s pram or pushchair, you guys say. And the third one is me with the pigtails. And as you can see, from today, as opposed to then, my eye is shut. So I live with third nerve palsy. Now, third nerve palsy is also very, very rare, and just a little bit about it, you can get it through trauma, like me, or if you have diabetes, you can have a third nerve palsy episode, which would possibly last between 2 to 3 months, and you can look like me when I was little. You could look like my eye, and it should be down and out to the side, but it's not. It just freeballs and does whatever it likes to do. Now, also, I was diagnosed to have a limited mental capacity. I wasn't supposed to get past year 10 or at 15 years of age. And do you know what I was doing when I was 15 years of age? I was an exchange student to Denmark. Så jeg taler dansk. I have just recently completed my PhD in the area of what is the lived experience of people living with facial eye disfigurement and their family members. Now, I wanted to interject when they were saying, oh, dear me, can't see that. I wanted to interject and say, yes, there is evidence to say that there is intrinsic negative bias towards people living with facial disfigurement. We are the least provided. If you've got facial eye disfigurement, we are 5 times more likely to be unemployed. These things are reality. But there is hope, because you are all here. There is some eye loss misconceptions, and you've probably read my slide already. There's oodles of them. But I would just like to bring up 3. There is a myth out there that has been debunked in academic literature, but not in the world that we live in. And that is, the greater the disfigurement, the greater the distress. That is where people go, it's just an eye. You've got the other one. yet they don't understand that we are forever thinking about protecting it, guarding it, thinking about whether or not people are going to interact with us normally, whether or not they're going to think that we have got a brain, that we can actually think and talk. And also we have a tendency to also minimise our own experiences because society puts on us that it is just an I. Whereas, you know, they think, and these are all technical words, and I'm sorry if I'm going to cause offence, but the more normal we look, our experiences are not necessarily heard or validated as much as if you have a more severe facial disfigurement or a visible difference. The second misconception that I would like to raise is, you know, we all know this, that medical intervention will not fix everything. And the third one is asking a survivor about their visible disfigurement will make things worse. And that's for you, all of you medical professionals. I know that I'm speaking also to the people who know differently, but us as survivors, if you ask us a genuine question politely, we are going to say thank you most of the time. You know, sometimes we can get lost. Oh, did it again. We can, you know, that way we can, you know, we all have our bad days as well. So we can then say yes. But I would think that the worst things that we could do is to stare and avoid rather than ask. So I'm going to bring up and talk about living with grief, as this is a part of my PhD findings. Now, I would like to say that my background is in education and counselling, and this is the first of its kind PhD, and also I've got all my findings published. That took a while, but it's there. And this is one of them. It's called chronic sorrow. And chronic sorrow is a lifelong feeling of sadness and loss. It's reoccurring, and it can intensify years after the initial loss. For example, and I want to walk around, but I can't. For example, for me, am I going to go to the prom? No. Am I going to be able to be loved? Is anyone going to love me? These are all things that survivors have and experience. So each part, like when their friends are going to get married or going out on dates, these things, this is when chronic sorrow can intensify. Chronic sorrow is a reaction to multiple and reoccurring losses over a lifetime. But not all is lost. These are the foundational blocks that throughout my PhD has found that combats this. So the more foundational blocks that you have of these, the more buoyant and the more not normal, but the more you're able to cope and act out of kindness instead of rejection. So the first is active, intentional decisions. You're in the middle, by the way, and everything just goes around, and it goes this way and that way, and oh, did it again. Third time. Can I do it a fourth? I'm not quite sure. So active, intentional decisions. For example, I was bullied. I was bullied to the nth degree. I had track marks up the back of my legs. I had black eyes. In secondary school, I was a victim of, was in a Catholic girls' school, and I was actually a victim of, not a victim, I was sexually abused by peers, yeah? So am I, just using me as an example, am I going to choose to be a victim, or am I going to actively, intentionally decide to be a victor, to rewrite that story into something more powerful? The second one is having a healthy self-esteem. Now, my doctoral findings found that this could happen with faith, such as myself, believing in Jesus Christ, or having a wonderful family around you that I actually, unfortunately, did not have. So it had to come through my faith. But if you have a family and a value-based system, that can be producing healthy self-esteem. The next one is forgiveness. Now, hands up if you've heard forgive and forget. I have. There's no way that you forget. So forgiveness is an active, intentional decision whereby we choose, forgiveness does not mean that it is not wrong, that you haven't experienced an injustice, that it is, it's not any of that. It just means that you give yourself permission to release them from the hurt that they may or may not remember that they've ever done to you. And the fourth one is resilience, which is basically self-autonomy, how you choose to self-govern. Do you choose to have active, intentional decisions? Do you choose to make good choices about the crap experiences that we all have sometimes? Do you choose to reframe them? Or how else do you choose to do things? My takeaway messages is grief is often ongoing. We have to acknowledge that grief and sorrow is a real thing that we deal with on a daily basis, or if not a weekly basis. Hands up here who goes to the supermarket and gets that stare. Hands up if you're a mother or a father that have had the stares. Yeah? Yeah. Same with me. I've got a 10-year-old now, and she's getting the stares. In another few years, she's going to be getting, so how are you, Zaylee? And then looking at my child to actually have her answer for me. Find and build community of support. That is very, very crucial. Everyone here today that I've heard has said the same thing, and this is the reason why this exists. And know that you are not alone, that your experiences are real and valid. And not only that, they are deserving of being understood and respected by everyone. Thank you. You can connect with us. And that's, I run Karibu Anawim, which means welcome to the way of victory. Karibu means welcome in Swahili, and Anawim is a Latinized Hebraic word meaning the downtrodden and outcast of society, or the victorious. So it's a welcome to the way of victory, and we provide counselling and professional development. Thank you.
Thank you so much. Erica, do we have time for any Q&A? Or have we run our time?
No, we do have time for
Okay.
Q&A, so make your way to the front. If you have any questions, we do have a virtual one from Karen. Question about survivorship. What are your thoughts on sending all retinoblastoma survivors to survivorship versus other treatment?
So I think the thrust of the question is, if you are a survivor not currently in survivorship care, is it worth having that done? I think I would answer that by saying it depends. In general, the answer would be yes, it is worth having that done. How it's done depends a bit on a person's risk, and I think that takes us back to the gene status and the prior treatment exposures that somebody has had. Certain kinds of chemotherapy, radiation isn't used much anymore, but for some individuals years ago, that is still the case. Individuals like that, I think, are going to benefit the most from a survivorship clinic. If you're unsure, I think that getting information is always a good place to start. If you have a primary care doctor who is looped into this, that can be a good starting point, but I think increasingly resources are available online, such as this organization or other cancer survivor organizations, where you can talk about your particular situation and then find out if there's a clinic in your area. I think it never hurts to have an evaluation done if you're unsure. At the very worst, it can be a one and done type of encounter where you can get a summary of your treatment and find out your current status, and then perhaps continue your care with your primary care doctor. So I think that type of visit can be very worthwhile.
Hello, my name's Sarah Haddad. I am an ocularist from Los Angeles, and being an ocularist, we see a lot of patients that unfortunately they don't have that support system from their family, and I think this is kind of directed towards Susan a lot, like as a social worker, how a lot of times I want to just give them these support groups, but I don't want to offend, and I don't, especially when I see them become teens. I see how retinoblastoma has affected them, and I see groups like this, and I want to share it without being offensive or offending the parents, and it's such a sensitive situation. And how would you recommend approaching something like that?
Well, first of all, I think it's great that you're even thinking about it. I really noticed in the last panel with the adult survivors that one of the people on the panel said that their ocularist was their person, and I thought that was so beautiful. I think people need, and studies have shown this, kids need at least one unconditionally loving and supportive person in their life. And of course we hope that it's one of their parents. It's not always one of their parents. Sometimes it's a teacher, sometimes it's a doctor, sometimes it's a social worker, sometimes it's an ocularist. And if you get to be that person or contribute to that person, go for it. I think if you're worried about, I don't think that you could be offensive. I'll be honest. I don't. I'm going to frame the answer a little more big than that, but the bottom line is, if you think somebody could use a resource, give it to them. Don't worry about being offensive in that way. Something you could do if you're concerned with looking like you're targeting one particular patient because you don't think that they're specifically supportive, come up with a one-pager that you can either give to every patient or not, but specifically give to that patient, and then it doesn't necessarily look like you're saying, you, Tommy, need help. This is a thing, a group of support that I give to lots of my patients. But I think the fact that you're asking the question in such a way, you're not going to be offensive. I know that.
Just having flyers around your room or anything like that would be a good idea as well, just for mums as well as the kids. Yeah.
Hi,
This is Melissa again. I just wanted to have a comment to kind of add on to what you've already said. I think one of the themes I'm seeing here is how important family is. And so I just wanted to say thank you to all the families who are here for your survivors. I think it's a testament that you're here today and you're trying to do better for your survivors and your family members. And just to remember that we really are impacted by how our families deal with our diagnosis and everything long term. And so something I'm hearing kind of underneath from the last two talks is that make sure you're taking care of your mental health, because your children will take their cues from you, and they need you to be there for them. So, but I think most of the folks here today might know that already, so thank you.
I just want to say thank you for all of your input, and I'm thinking about things in a different way now. And I also wanted to say, as someone who's had multiple experiences with different types of cancers, you, as a family and as teenagers and as kids, you need to teach your kids how to keep track of everything they've gone through. I have what's called, for myself, a medical resume, and it lists chronologically everything that has, it's a short version, but I take it to every physician and every testing place, and they look at it and they're like, oh, we have to think in a different way and take into consideration all of these other things that you've gone through, so that we can see what is it we're looking for and how to approach it. And we need resources like you guys to keep giving us information, even if we're resistant to it because we're a haughty teenager who doesn't want to have the help, or we're a parent who thinks we know better. So thank you, and just keep giving us more and more information.
I'm glad I'm not the only one in the room that has a medical resume.
Clay, again. I just want to thank...
There can never be enough Clay, okay?
I just want to thank the panelists for this presentation. Each and every one of you gave me something to think about, and each of you, I think, epitomizes what it means to be a survivor. So hats off to all of my fellow survivors in this room. And I don't think, unless you've walked the journey that we have had to walk, you realize the strength, the trials, the tribulations, but ultimately the resilience that it requires to be a survivor. So thank each and every one of you for what you have offered, because we may seem strong at times, and I think all of us are strong at times, but at least for me, and maybe for somebody else in the room, we get a little weak. And the key is when we fall down to get back up. And so this panel has shown to us what it means to keep stepping, putting one foot in front of the other, and going on in strength and going forward. So thank you all very much.
My name is Patrick Loyer, and I'm here with my daughter Camille. We are ocularists in Melbourne, and I've been an ocularist for 42 years now in Paris and in Melbourne. And pleasure working with Sandra Staffieri and all the teams there, and you know how wonderful they are. Now, I have some question, an important question to ask, but before that I would like to tell you that all what I've heard today, and it's very exciting and very stimulating and enriching from all the different people here, but as an ocularist, I'm motivated for a long time to help people with my services need, and who need my services, sorry, and I feel blessed. And I was talking to another ocularist, Sarah's dad, and we have the same feeling. We feel blessed and privileged to be able to help people like you guys with our modest skills, but we are and that's the reason I'm here standing in front of you, is just to explain also that my feeling when I come and see all this group of people is that everyone has, with one eye, two eyes, or no eyes at all, because I see people without eyes, we all have our understanding from where we stand and from our personal experience, and which is, we can't ask for more than that, but in fact I'm trying to ask for more than that. I would like to ask for more than that, and that to me mean a centralization and a dissimulation, a distribution, if you want, of all this knowledge, of all this experience, and interaction and intercommunication with a different group of people, whether they are the patient first, because everything is directed for the patient and should be, but all the different medical aspect of the support should be interacting with the patient, for the patient, and with each other, understanding that the ultimate goal is your service to you, in whichever best way we can give. And so that's one thing. I'm not so much liking the word of survivor. I understand, and I'm not, I'm never pretended to be in the shoes of people that I try to help. But I don't so much, I would like more than survivor. And I will explain to you quickly why. I was talking to a patient of the mother of one of my patients, who come from a group who have been slaughtered and bombed recently for the last year. And we were commiserating about the lack of the moral vacuum that we are living in, or that this group is living in since then, and the lack of support, the lack of empathy, the lack of care, which I found very similar to what the group here experienced for different reasons, at different level, I understand. And I said to her, I hope we survive, and things that we didn't expect would be forced upon us again. And she said, not survive, thrive. Thrive. I want my people, which you are, because I've been doing that for so long. By the way, I'm going to annoy you, but I want you to not just survive, I want you to thrive, because you are. And I will explain to you why you can, why I believe in you. I've seen people, most of my patients, not all my patients, obviously, because it's not just dependent of who they are, but also their surroundings, their support or lack of, and all sorts of things. But I find that, couldn't understand why, but most of them were just definitely above the average in whatever jobs they were doing, whatever sports they were doing, whatever activities they were doing. I could show you painting of a tigers and a one-eye patient. One of my patients did. You would believe that it's a photo, and she did that with one eye and one little brush. I promise you, if 99% of you will think it's a photo, oh, great. And I'm a painter because I paint irises all the time, so I could recognize so much talent. All that to tell you that the only eventually drop on me, you guys are loaded with something which is nobody's prepared to, and you are becoming above the average, better, for several reasons. One is because you believe in yourself eventually and fight people who push you down, and you are going to show yourself that you are just as good as everybody else, and you are going to show the world that you are as good as everybody else. And you are going to work harder, and you are going to train harder, and you are going to do that in your driving because you double check and you become a better average driver. You go slower, don't take stupid risk, etc., etc. So you are going to work harder every day, every second of your day, and you are going to become a better whatever. And so from those people, I just want to say, you are not just survivor. You are 150%. When I hear you talking about normal, you are 150% normal for me. I promise you. Because you are not only as capable as the next person, but you have grown courage, endurance, and etc., etc. All the things that you know, okay? So after that, after my little speech, and I'm sorry for all that, but I will have a question is, because it's important for me, and I'm only on a path, just like you are, with you. So I want to hear from people in the audience and you, what was good for you in terms of your services, the services that you got from ocularists, and no, maybe not just for that, but I'm interested, I'm a bit biased, from ocularists. What was good, what was not good, what you were wanting to, what you would have liked to get, okay? So I'm starting with me. I want to hear things which, not so much the good, but what was not so good and where I can improve and how I can help as an ocularist, because we are going after that with Camille to Chicago, to the academy there, and I'm sure I can dissipate, give the information to all the people there. What can we do as ocularists to be of better service? What should our service include? What is important? How can we be a 5 seconds in your shoes to know what you need? Okay, so that's what I want. Thank you.
Thank you. I personally, and I don't think anyone else on this panel, has got a prosthetic eye, but perhaps just having the one thing that I would say is to know where they could receive some psychosocial and psychological help, because you see them on the cold front and they are more, they've got more time and space for you to say, hey, this must be tough, have you thought about? Or here's something for later. Just, I don't mind if you want to screw it up or put it on the fridge, whatever you would like to do, but just, you might want it for later on. I hope that it's very short, but thank you.
Erica, are we okay on time? We're done.
We are ready to wrap it up. It is break time.
It's break time. What time are we back, Erica?
3:40 for the parent perspective.
Yes, thank you, everybody. Thank you.